since we only have 2 chapters that cover respiratory drugs, it seems like a good place to add this. So when you're looking at chapter 41, look at the objectives for this course, and I'm really going to narrow in on what I have seen in practice, and then what I know is on NCLEX and HESI about this one. So it's not as dense as it I guess otherwise could be, because we're going to focus in on what you need to know just for the rare occasions that you might encounter a patient with active TB. Goes into a little bit about the tuberculosis illness itself. I want to point out a few things when we have a patient on tuberculosis precautions. They're airborne precautions, so they're usually in a negative air pressure room. We have to gown, mask, and glove up every time we go in and out of the room, so we try to minimize the times we go in and out of the room. So it really takes into consideration good planning when we go into the patient's room. And then noting how we've pretty much eradicated this, but we're seeing an increase, a slight increase, uptick in tuberculosis in the United States. I think the latest data that I've seen was there was a large influx in Tulsa, Oklahoma, and they were trying to track down where that came from. So when we're looking at our anti-tubercular drugs, I want you to look at the outline, because on our outline we're looking at basically 4 drugs. Typically, because when we treat patients for tuberculosis, they become resistant to medications. It'll even say that up here. They become drug resistant, and because of that multi-drug resistance, we'll typically put patients on a cocktail of all 4 of these medications. So if you'll read through your teaching notes, I have a lot of information that's really summarizing this top section of our tuberculosis, so you understand that, and then you understand the drugs that we're going to be talking about, and then we'll look at each one of those. So the major effects of my drug therapy include the reduction of cough, and therefore the reduction of the infectiousness of the patient that normally occurs within 2 weeks of the initiation of drug therapy, assuming that the patient's TB strain is drug sensitive. With appropriate antibiotic treatment, most cases of TB can be cured, and successful treatment usually involves taking several antibiotic drugs at least for 5 months, and sometimes as long as 12 months. That tends to be an NCLEX question. So because of that long period of time, it's important that we set them up with public health, so that we can continue to monitor their progress. Non-adherence to the prescribed therapy is a serious health issue, because that can make the TB more drug resistant. So nurses can play an important role in encouraging adherence to that regime on that medication. The indication for all of these medications is prophylaxis or treatment of tuberculosis. Contraindications are severe drug allergy and major renal or liver dysfunction. So think about assessing their renal status and their liver function. There are some good table 41.3. Scroll down to that lists our common adverse effects. They're fairly well tolerated. Asanazide, one of the usual mainstays of treatment, is noted for causing peroxidine deficiency, which is a vitamin deficiency, and liver toxicity. So we'll want to monitor our patients for that. And then table 41.4 shows some good examples of drug interactions with our medications. When we look at our specific one, the first medication we're going to look at on this, I call it a cocktail, so our anti-tubercular cocktail is my INH, or isoniazid. It's the mainstay treatment for tuberculosis, most widely used anti-tubercular drug. It can be either used as a single drug for prophylactics or combined with other tubercular drugs for the treatment of active TB. It's bactericidal, so it's going to actually kill the infection itself. It's metabolized in the liver, though, so we want to make sure that patient has a good functioning of their liver. Let's see. It also has it's noted to cause pyroxidine, which is vitamin B6 deficiency. So frequently we'll have to give patients supplements of vitamin B6 while they're taking this medication. My next one is rifampin. Rifampin's a broad spectrum bactericidal drug. It kills the offending organism. It's used either alone in the prevention of TB or in combination with other anti-tubercular drugs. It can be in both oral or parenteral formulations, and it's usually in combination with inoside. It's contraindicated in patients with a known drug allergy, and it's a potent enzyme inducer, so it's associated with many drug interactions. Again, going back to reference table 41.4. To note for NCLEX, it may cause urine, saliva, tears, and sweat to be red, orange, or brown colored. That's a normal adverse effect or a side effect of that medication. So someone will get that on NCLEX. Keep that in mind. Streptomycin is my next one. Right there. Streptomycin, currently available in generic form. It's used. It has a lot of toxicity. It's usually used in combination with some of my other drugs to treat the multi-resistant TB infections. On your outline, I mentioned PZA, but that doesn't seem to be the mainstream treatment as much anymore. So we're gonna limit it to that inoside, rifampin, and streptomycin. Scrolling to the end of the chapter, if we're assessing, we want to know what we usually see in patients that have tuberculosis. So think about it being night sweats, loss of weight, and a productive cough. And then as I'm giving the medication, we need to teach that they might have to stay on the medication for up to a year. If they live in crowded conditions and someone else starts to display side effects of TB, that person needs to get their own prescription for this medication. The prescription doesn't need to be shared. Everybody needs to get their own prescription for that one, and everyone will need to stay on that medication for the duration. And then if it's working, our evaluation would be, are we seeing a reduction in productive cough and night sweats? And then when we do a chest x-ray on the individual, are they noting that the active TB is now dormant in the lungs? Do pay attention to the two things I pointed out, that isoniazid causes the vitamin B6 deficiency, and then rifampin can cause the urine, saliva, tears to be red, orange, or brown colored. So that would be a teaching aspect to make sure they're aware of that.